So good afternoon, everybody. Our didactic topic for today is neutropenia risk with the antipsychotic medications. So this had been, I guess, spurred on by some discussion earlier this year as there were comments and changes made to the clozapine REMS program. So we will take a peek at overall neutropenia risk with our antipsychotic medications. So objectives, we're going to look at the categories of neutropenia. So we have three different categories. I really am lumping them all into one for the sake of this, just because that's the way most of the case reports are. We'll talk about the proposed mechanism. So there are two potential mechanisms for how this happens. And then we'll compare some of the reports of neutropenia. So who is it happening in and which medications have been implicated? We'll start at the top, though. So looking at neutropenia. So neutropenia is a decrease in neutrophils. So neutrophils are one of our white blood cells that are mobilized to be able to fight infections, especially bacterial infections. Neutrophils are fairly important. So they tend to make up between 45 and 75% of all of the circulating white blood cells. So it's really a powerhouse in terms of our immune system. Now, as they decrease, we have different levels of decrease. So mild is when the levels drop between 1,000 and 1,500. Moderate is between 500 and 1,000. And severe tends to be when they're under 500. Severe has also been referred to as agranulocytosis. So agranulocytosis really referring to the fact that neutrophils are one of the granulocytes and that it can be non-detect. So we will see a couple case reports where patients fell that low. I will say with more recent laboratory analysis, we don't see as many that are completely zero. They may be below that 500, but not down to total zero, which is a good thing. Without having white blood cells, it does put patients at increased risk for infections. Unfortunately, there's not really a good indicator that a patient's neutrophils have fallen. So oftentimes they may be asymptomatic, which again is a good thing. If they do have symptoms, it tends to be symptoms of an infection. So they may have sore throat, pain other places. They may be running a fever, have chills. So we really want to, it'd be ideal if we could identify the decrease in neutrophils before a patient gets sick, although that may not always be possible. Now, neutropenia can happen naturally. The prevalence is between 3.4 and 5.3 cases per million in Europe and 2.4 to 15.4 cases per million identified in the United States. So we can see it outside the use of medications. And there's a number of different potential causes for that. Genetically, patients may be at a greater risk for neutropenia if they have infections, if they have significant allergic reactions, if they have an autoimmune disorder, sometimes with pretty significant bone marrow suppression or deficiencies, including vitamin B12 deficiency. So we can see it due to a whole bunch of different reasons. I want you to keep that in the back of your mind because the medications may play a role, but they may not be the only thing that's happening. We are going to focus kind of on the drug aspect, though. So drug-induced severe neutropenia. So the most severe, looking at less than 500 cells, is at a rate of 3 to 12 cases per million. So it may make up a pretty decent portion of the number of neutropenia cases that we see, at least here in the United States. Because this is the most severe form, patients don't have many white blood cells that are available, which means that they may not be able to mount a response to any type of infection. And with that comes the potential for mortality. And the mortality rate ranges depending on the population that you're looking at, but the widest estimate I could find is between 5 and 20%. The 20% gives me concern because that's, we're looking at a pretty decent number. 1 in 5 of those patients may unfortunately pass away as a result of getting that infection. So if we can identify it ahead of time before patients are sick, that's really what we're hoping to do. Now, which meds may cause problems? Well, we have a whole bunch. Antibiotics, anti-neoplastic agents, so the agents that we use that target cancer cells often wipe out most of the bone marrow. Antiplatelets, antipsychotics is what we're going to focus on. Our anti-seizure medications, anti-thyroid medications, other immunosuppressants, and non-steroidal anti-inflammatories. Now, I'm going to put a little asterisk next to the NSAIDs. I will say that in the case reports we're about to look at, you'll see that patients sometimes are on multiple medications. I don't believe that all of the case reports that we had really capture if patients are taking over-the-counter medications. So it is possible that they play a role in some of the case reports we're going to look at, but for the most part, we're going to focus on the antipsychotics. So how might this happen? What might be causing these medications to result in neutropenia? Well, there are two potential mechanisms. So one is an immune-mediated reaction. So the medications either themselves or binding with other proteins in the body may activate the immune system. So they activate the immune system to specifically target the neutrophils. Now, why does that happen? If you look at the structure of all of those different classes, it's vastly different. So it's not incredibly clear exactly what that trigger is, considering they all would then create antibodies for the neutrophils. So if the target's the same, we should see something that's pretty consistent. They've not been able to replicate that in the lab. So when they measure for antibodies, they're present in a number of these cases, but there's likely an intermediary step, which we're not clear on, that results in this particular reaction. The other potential mechanism for developing neutropenia is that there's toxicity. So there may be specific toxicity to the cells that produce our neutrophils. So if we're not able to create them, and it may be at any level above that, and that direct toxicity may wipe out most of the neutrophils that are available. So two potential mechanisms, again, not well replicated in terms of in the lab to be able to say, yes, this is absolutely this is absolutely that. I would say the anti-neoplastic agents are mainly the toxic ones. Our anti-seizure medicines tend to fall more in that toxicity area where they're just toxic to those cells that create new neutrophils. Our antipsychotics, it's not quite so clear. So either potential mechanism, either way, this is a concern that we need to make sure we're monitoring for. So which medications does this affect? Well, there are reports with a number of both first and second generation agents. I think when individuals think of neutropenia and antipsychotics, clozapine pops to the top of the list. So we had a well-established REMS program where we had to do very specific monitoring for a while. That has been rolled back. But that really was the one that we focused on. So sometimes it's not as obvious that this can be problematic with the rest of the medications. So the way that I set this up moving forward is I looked, there are no controlled trials. Most of the reports are all case reports. So this is why it's super important that if we do come across a patient situation where they have some of these toxicities that aren't super common, that it does get reported so that we're able to share that and all learn from it. So we're going to look at case reports of relatively individual antipsychotics. And then we're going to look at a couple situations where patients responded and developed neutropenia to multiple different antipsychotics. I saved clozapine to the end. There are more reports for clozapine than any of the other agents. I just kind of did this more as a review because my guess was most of you are familiar with the neutropenia risk with clozapine, and we really wanted to explore some of these other agents. So we're going to start with chlorpromazine. So chlorpromazine had at least 3 different case reports. So a 39-year-old female who was admitted to the hospital with a psychotic illness. She was started on 2 different antipsychotic medications. So chlorpromazine and trifluoperazine. So both of them were on relatively lower doses. So it was 300 milligrams of chlorpromazine, 30 milligrams of trifluoroperazine. Patient had been on it for a while. Psychotic symptoms were stabilized. They actually reduced the dose of the chlorpromazine. And when she was following up as an outpatient, they noticed that her white blood cell count had been 1,100 when she was in the hospital and had dropped all the way to 1,600 a month later. So there was pretty significant concern that that was a precipitous drop over 4 weeks. Thankfully, she did not have symptoms. They discontinued both medications. As time went on, the patient continued to be symptomatic, so they reintroduced chlorpromazine. So they introduced chlorpromazine, they titrated her up to a dose of 400 milligrams, so even higher than what she'd been on before, and they saw her white blood cells drop even further than what they had been. So despite the fact that they had resolved, they did see a recurrence, and there were no measurable neutrophils. So this was one of the examples where that severe neutropenia, she was classified as that. They discontinued the chlorpromazine and saw resolution in her white blood cell count afterward. So pretty clear association with decrease in white blood cell count with the use of chlorpromazine. The second case report was in a female, 73-year-old female that also had psychosis, was admitted to the hospital. She was started on chlorpromazine 75 milligrams. And they saw a drop in her white blood cells also from 4,620 down to 3,500. Now, this did not quite hit the threshold of neutropenia. However, because of her age and other medical conditions that she had, although they did not specify exactly what they were, they felt that she was at risk for being immunosuppressed and discontinued the chlorpromazine. They saw within the matter of a week that she did have a resolution in her white blood cell count. She was not rechallenged with the chlorpromazine. So smaller dose of chlorpromazine, older patient, comorbid medical conditions, they saw also a decrease that caused concern. Last case for chlorpromazine is a 55-year-old female, also admitted to the hospital with psychosis, was given chlorpromazine. They didn't give me a dose on this one. And the white blood cells, she was admitted, she also had a urinary tract infection. So her white blood cell on admission was 10,900. With the use of chlorpromazine, over the course of her hospitalization, they saw the white blood cells decrease down to 2,860. There was pretty significant concern that she was going to have a recurrence in her infection, so they did discontinue the chlorpromazine and again saw a resolution of her white blood cell count once they discontinued the medication. So in each of these cases, the chlorpromazine really was the main focus that they believe was responsible for the reduction in the white blood cells. Might it have been the only thing? No, but there is an association. Quetiapine was the next one I was able to find that a little bit more independently was associated with neutropenia. So the first case report is in a 33-year-old African-American female. She was admitted to the hospital with schizophrenia. She was originally started on quetiapine 400 and divalproex sodium 500 milligrams. So she was followed for a period of time. Her initial blood work, you can see there, not too much of a concern. So 6,200 with 63% granulocytes. They didn't give me a specific neutrophil count. The granulocyte percentage includes neutrophils, eosinophils, basophils, and mast cells. So we can't quite tease them apart specifically, but they did see a reduction in both white blood cells and the percent of granulocytes over time. She had been on that regimen for a little bit. Her numbers had remained stable. She was not necessarily responding to the quetiapine divalproex sodium, so they discontinued it. They tried a couple other agents, were not getting any resolution of symptoms. They revisited the quetiapine divalproex sodium. When they revisited it, they titrated her quetiapine up to 800 milligrams, so double the dose that she'd been on previously, and her divalproex sodium was up to 2,000 milligrams daily. Not long after they had increased and maximized those doses, they saw a pretty significant drop in both white blood cells and the percent of granulocytes. So they discontinued both medications and swapped the quetiapine for the aripiprazole. So it could be argued, is this due? Anti-seizure medicines can also cause neutropenia. Was it clearly due to the quetiapine or to the divalproic sodium, maybe due to both being on board? That's not incredibly clear, and maybe it was dose related, considering her numbers held pretty steady when she was on those lower doses at first. But with that re-challenge, they did see the precipitous drop. The other case report for quetiapine was just quetiapine. So this was a 24-year-old African-American male that was admitted for schizophreniform disorder. While he was in the hospital, they started him on quetiapine. His white blood cell count was 3.7, so a little bit on the lower side already to begin with. His ANC was 1,125 after 2 days of treatment, and he was on 25 milligrams twice daily. So very low starting dose. His white cell count dropped to 2.8 and his ANC was down to 504. So he was right at the bottom of the moderate neutropenia. So they discontinued treatment with the quetiapine and did see a resolution in his white blood cell count. So that was an interesting one because it was just the quetiapine at a very low dose, and they still saw a pretty significant drop. So other second-generation agents that have been reported, so paliperidone or Invega. So there were two. The first was a 45-year-old male who had schizophrenia, hepatitis C, as well as alcohol dependence. He was started on paliperidone, the long-acting injection, and they saw a decrease in his white blood cell count. So that his neutrophils actually dropped to 0.94, so 90. Those 9 should be superscripted. So it dropped pretty significantly, and he was closer to that severe neutropenia threshold. They discontinued the paliperidone. They had to wait while his body processed the injection, and they did switch him over to oral risperidone. So his as the body got rid of the paliperidone, they saw a resolution in his white blood cell count. They started the oral risperidone, and they saw his neutrophils drop again. So to 0.72, even lower than when he was on the paliperidone. They discontinued the risperidone, and they again saw a resolution. So this was interesting. Paliperidone is the active metabolite of the risperidone. So the patient really was sensitive to both of them. Granted, he did have hepatitis C. It's unclear if that infection was active at the time, which may also contribute and be a risk factor for neutropenia, but pretty significant neutropenia identified in that patient. The other patient case report is a 33-year-old female. She had schizophrenia, was admitted to the hospital. They started her on paliperidone. She was on 6 milligrams. Initially, at baseline, her white blood cell count and ANC were normal. They increased her to 9 milligrams over the course of just a couple days. And about a week later, they checked her complete blood cell count again and saw a pretty significant drop. So white blood cells were down to 2.96 and her ANC was down to 1.18. So they did discontinue the paliperidone and saw a resolution in her white count within a few days. So in both cases for these, they really were, the paliperidone was the main new agent that had been started before they saw that precipitous drop. So they did believe that this was associated with the paliperidone use. Yeah, couple more that are individual, and then we'll look at some of our combo agents. So flashing back to our first generation, there's a case report with thioridazine. This was a 68-year-old Caucasian female. She did have psychotic symptoms, was admitted to the hospital. She was on both thioridazine and disipramine, but she was on starting doses of both. So 35 milligrams of the thioridazine and 25 milligrams of the disipramine. They saw her white blood cell count was 3,150. It had been normal on admission, and she presented with symptoms of an infection. So fever, chills, body aches, as well as a sore throat. They discontinued both the thioridazine and the disipramine. They started her on perfenazine, and they did see a resolution of both her symptoms as well as the white blood cell count. Another first-generation agent, so we've got this one in ziprasidone, then we get to our combo agents. So thiothixine, 27-year-old male, was admitted to the hospital due to suicidal ideation. He also had schizophrenia, no other medical conditions, and his lab work had been normal. So all of the lab work had been normal, within normal limits. They started him on thiothixine and haloperidol. I did not get the doses on them. And he did develop neutropenia. So they said it was moderate neutropenia. So he had dropped pretty significantly. They discontinued both agents and did have resolution within about a week after discontinuation of the medications. They did not re-challenge. And then last single case reports. So ziprasidone has a couple. One is a little bit of a combo, but 19-year-old African-American female. She also was admitted to the hospital, schizophreniform disorder, had been on olanzapine. White blood cell count was 2.78. There was a little bit of a concern. Her ANC was 731, so she was in that moderate category. So they switched her. They switched her to ziprasidone and started mirtazapine. So the hope was it was less likely to cause neutropenia. Well, they saw a further reduction. So they saw a decrease in the white blood cells to 2.63. In the ANC, now she was in the severe category because it fell to 499. So they discontinued both of those medications, and she did have resolution of her white blood cell counts. The other case report for ziprasidone is in a 45-year-old African-American male, had a number of different medical conditions, so was admitted for medical reasons, but had a history of schizophrenia. Patient had been somewhat questionable adherence of both medications and had stopped going to dialysis, thus the admission to the hospital for medical reasons. Patient was restarted on ziprasidone, was on 60 milligrams twice daily. They also restarted the hemodialysis, and they noted a pretty precipitous drop in the white blood cells after starting back up both dialysis and the medications in a supervised manner. They believed it was due to the ziprasidone. They discontinued the ziprasidone and did see resolution of the neutropenia. So that was interesting. Again, a patient with some other comorbid conditions, possibly due to maybe some inflammation as a result of not going to hemodialysis. That may also have been a contributing factor, but they did identify that ziprasidone discontinuation then did result in an improvement in their white blood cells. So they thought there could potentially be a relationship there. So far we've looked at kind of a few more individual medications. There are also some case reports where patients were serially on antipsychotics and continued to have some of this neutropenia. So we saw one with the ziprasidone and the olanzapine. Here was another one, 39-year-old female with schizophrenia. Had been on paliperidone, a long-acting injection. They could only push the dose so far because she had intolerable side effects. So they lowered the dose and actually added lurasidone. So she was on about 80 milligrams daily, had been titrated up. As they did their traditional routine blood work, they noticed that she had gone from white blood cells within normal limits to being significantly decreased. So her neutrophil count was 1.04, her white blood cells were 2.45. So they did discontinue both of those medications, and they continued to monitor her blood counts, and they did resolve over time. With the long-acting injection, the paliperidone does stick around for a while, so it did take them a little bit to see full resolution of those lab results. Two more. So this case report was in a 21-year-old Asian male. This patient had conduct disorder and had been started on olanzapine and valproic acid. So olanzapine was 10 milligrams. Patient was on valproic acid. They had been stabilized on this treatment regimen. Labs were normal. When they were admitted to the hospital, they were discharged on the regimen. At follow-up, a little more than a year later, their ANC had gone from 1.49 down to 0.63. So fairly significant decrease. They discontinued both medications and saw a resolution of the neutrophil count. They then, the patient continued to have pretty significant symptoms. And they believed that maybe the neutropenia was due to the valproic acid. So they only introduced the olanzapine. When they introduced the olanzapine, they introduced it at 5 milligrams, and they saw the ANC drop again to 0.98. So that was a pretty significant concern. They discontinued the olanzapine. They saw it resolve. So it was back over 2. They needed to treat the patient and their symptoms, so they started risperidone. They start risperidone, the ANC dropped again to 1.17. Now they discontinue the risperidone. They see the white count and the neutrophils return to normal, still has symptoms. So they start aripiprazole and lithium. Patient does well. Symptoms are under control, and the white blood cell count did not decrease. Interesting thing. So lithium can actually cause leukocytosis, so it can increase the neutrophils and the white blood cells. Well, the patient is discharged on this regimen, doing well, starts to have adverse effects from the lithium. So they decide, you know what, patient's doing well, let's taper and discontinue the lithium. They taper and get rid of the lithium, and the ANC count drops. So just on aripiprazole, they saw the ANC drop to 0.97. So they discontinued the aripiprazole and again saw resolution of that white blood cell count. So this was an interesting case where with different challenges of antipsychotics, they continued to see that ANC drop. So it does suggest that there may be patients that are sensitive across the board to all of the antipsychotics. So I would encourage you to keep that in mind. If you have a patient who had neutropenia, maybe we want to keep an eye on them a little bit closer if they do need to be on antipsychotics. Last one, so this was a 41-year-old African-American male. Patient had schizophrenia and hypertension, had been using risperidone, and the white blood cell count dropped from 6 to 3.6. So they were concerned about that precipitous of a drop, and they switched the patient to haloperidol. So patient was on haloperidol. They did see an improvement in the white blood cell count, so they continued. They titrated up. Patient ended up on 7.5 milligrams twice daily with continued use over the course of a couple weeks. So white blood cells came up, they tapered the haloperidol, and then they saw a decrease in the neutrophils again. So it went from 1.8 down to 1.1 in the ANC. So they were like, okay, we need to get rid of the haloperidol. They now switch from haloperidol to lurasidone. So lurasidone was slowly titrated up, 20 to 40 to 80, then to 120. They saw an improvement in the ANC. Once the patient hit 120 milligrams daily, they then saw the ANC drop, so from 2.4 to 1.4. So they immediately decreased the dose from lurasidone 120 down to 80 milligrams, and they did see the ANC increase back up to 1.8. So able to stay above that threshold of not being neutropenic, but interesting because it was somewhat dose related with the lurasidone. So again, another example of a patient who appears to be overly sensitive to the antipsychotics, having neutropenia with risperidone, haloperidol, or haloperidol, easy for me to say, and lurasidone. So it shows up with most of them. Despite that, I didn't want to not include clozapine since this is one of the biggest ones. It does still have the black box warning for severe neutropenia. The new labeling is not as prescriptive. So in the past, when patients started, there was baseline blood work that was done where we needed white blood cell count and ANC, and then weekly for the first 6 months, every 2 weeks for the next 6 months. And as long as things were normal, we could monitor with blood work once monthly. It now is, we need baseline labs, we need regular blood work, and then if we discontinue, we need to continue monitoring for at least a month afterward. But it is no longer required that we check it every week, every 2 weeks, and then once a month. So the hope with that really is that we increase access and utilization of clozapine. Doesn't mean the risk isn't there. So the cumulative risk at 1 year is 1.3%. So 1.3% of patients may develop severe neutropenia if they're on clozapine. There were 585 cases total through 1997. I was trying to find more updated data, and I couldn't find it with a good time frame. So definitely still happens. If the neutrophil count drops, we just increase frequency. If they develop moderate neutropenia, so if they're below that 1,000 mark of ANC, then at that point, we really need to start interrupting therapy, and definitely if they're under 500. But the good news is the most frequent identification of neutropenia is within essentially the first year of therapy. We see most of the cases within the first 3 months. That may also be because we're tapering up the dose during that time frame, but it is something to keep in mind that we need to monitor a little bit closer early in therapy. And once patients have been on it and been demonstrated to tolerate it relatively well, maybe we don't need to monitor quite as closely. There are not specific recommendations for how often you need to do that, so that has been left to prescriber discretion at this point. So in summary, neutropenia has been reported with many of the antipsychotics beyond just clozapine. So this is not just a clozapine problem. It's been identified early, but in some of those cases, patients had been on treatment for at least a year, if not longer. So recognizing that there is a risk, we don't have standard guidelines in terms of how often we need to monitor a complete blood count. It would be helpful to make sure we have a baseline level before they start an antipsychotic, and then make sure we're at least routinely checking that, because it can be silent and we don't want it to pop up after the patient already has developed an infection. So that's what I have for today. Stop my share, and I'll turn things back over to you, Nicole.